Hi, this is Manos Brilakis from the Minneapolis Heart Institute, presenting Case 84 for the second edition of the Manual of CTO Interventions. This is a case that was done with Dr. Victor Sassi and Dr. Imre Ungi in the Sector 2017 meeting in Szeged, Hungary, and was put together by Dr. Judith Karaksoni. It is a case of an ostial right coronary artery chronic total occlusion due to in-stent restenosis. The patient had significant class 4 angina. He had undergone multiple PCIs to the right coronary artery, the first one of which 7 years prior for ST segment elevation myocardial infarction, and he was found to have RCA CTO 5 years prior to this presentation. He continued to have angina, and he was now referred for PCI of the RCA CTO. The RCA was engaged with an AL1 guide and the LAD with a 35XB 8 French guide, and dual injection demonstrates collaterals from the LAD to the distal right. There is an ostial RCA occlusion. The length is about 40 millimeters, and here is the previously placed stent. This is the area of view, also demonstrating no significant disease in the left, septal collateral supplying the distal RCA in the PDA, ostial occlusion of the right coronary artery just proximal to the previously placed stent. Therefore, if we put everything together, the patient has an ostial occlusion with an approximately 40 millimeter long occlusion due to in-stent restenosis, has good quality distal right coronary artery, and has septal collaterals from the LAD. Given that cross-pose works fairly well for in-stent restenotic lesions, the plan was to first try with a cross-pose catheter, followed by an Antegrade wire escalation, and then retrograde approach if everything else failed. The cross-pose was inserted to the proximal cap using a pilot 200 guidewire. Despite having an AL1 8 French guide, support was not the best, and we had significant difficulty advancing the cross-pose, in part because the RCA took a significant turn immediately after its origin going down. We tried to change to microcatheter, so we inserted a Corsair microcatheter and tried several wires, including a Confianza Pro 12, a Hornet 14, a Pilot 200, and a Gaia 2nd. However, we were still unable to make much progress. That was the furthest we could go, which was proximal in the right within the sub-stent area. Given the failure for Antegrade progress, and since we had good collaterals from the left system, we decided to go for Retrograde. This is a Corsair long microcatheter, and we did surfing with the Sion guidewire, and the wire found a pathway, and we were able to advance fairly easily into the distal right coronary artery after some guidewire manipulations. There's a controversy whether the septal is better, surfing is better, or whether contrast guided is perfect. There's no really perfect answer, but if surfing works, it can be a very time efficient way. As you can see in this particular fluorostor, crossing happened within less than 1 minute. We had, however, significant difficulty advancing the Corsair through, but after we dilated with a 1.5 millimeter balloon, the Corsair could be advanced all the way to the mid-right coronary artery. We then did multiple attempts to try to stay within the previously placed stent using wires, the Pilot 200, Gaia 2nd, Hornet, Pro 12, Miracle 12. However, we were unable to make progress getting into the distal cap inside the occluded stent. Therefore, after a lot of time, we decided to switch to the subintimal technique. We did have Corsair fatigue, and that is why we changed to a caravel microcatheter. And by doing that and creating a knuckled wire, we're able to advance in the sub-stent area all the way essentially to the proximal cap. We then used the Antegrade guide to advance an Antegrade guide wire. That was very, very challenging, and we did some attempts to see if we can re-enter from the retrograde microcatheter, but the wire was in the subintimal plane inside the aortic wall. We did then the retrograde Carlino technique. And by doing the Carlino now, we can have a better appreciation of the subintimal space and try to reduce some of the resistance to Antegrade wiring. And indeed, after doing that, we were able to advance an Antegrade Hornet 14 parallel to the retrograde guidewire. We had a lot of difficulty advancing a balloon over this Antegrade wire, but finally with the threader microcatheter, we were able to advance and dilate the segment within the previously placed stent. Then we did essentially a modified reverse cart. The guidewire, the retrograde guidewire was advanced. The Antegrade balloon was inflated, deflated, retracted back. In a way, this is the draft technique of Mauro Carlino's. And at the same time, while we were retracting, we are pushing the Antegrade guidewire, and the Antegrade guidewire eventually finds its way into the Antegrade guide catheter. So there's always be a tricky re-entry when we have angulation, especially within a previously placed stent. But again, with multiple attempts, then success can be achieved. As is the case, we see now the wires finally entering into the Antegrade guide catheter. We were able to advance the caravel all the way to the Antegrade guide, and then we externalized an RG3 guide wire. Multiple balloon predilations were performed. Drug-eluting stents, a 3.5 by 38 mm long, was deployed and post-dilated with a nice result and restoration of Antegrade TIMI3 flow. And of course, we're super happy and ready to finish. However, we should never relax, because immediately after that, the shaft of the NC balloon used to post-dilate the stent came out, but the balloon did not, and the balloon tip remained inside the Antegrade guide catheter. So this is a challenging situation, especially because we have an externalized guide wire. If we had just a regular angioplasty, it would be very simple. We would just advance a balloon next to this fractured balloon fragment, inflate it to make sure it doesn't move, and then remove the entire system. But the problem in this particular case is that we have an externalized guide wire. So we cannot do any trapping, because that would mean we'll trap the externalized guide wire and put a lot of tension to the heart. So how to retrieve that becomes a little more complicated. We tried to cine the guide catheter to determine where the fracture was, and that was pretty hard to see despite doing a cinerun. We finally deciphered, looking at the fragment we had, that we had enough segment of the balloon catheter inside the guide that we would be able to retract the guide and still retrieve the fractured balloon. So the guide will start bringing it back. And unfortunately, as we're bringing back, and maybe because of friction and the balloon fragment being on over the externalized guide wire, the balloon now starts coming outside the guide catheter, which is a little worrisome. However, once again, we did know that we had the fairly long fragment of the balloon, therefore the tip being out was not such a big deal. We finally kept on pulling the guide catheter back, and fortunately the balloon kept on coming, although it's a little further away from the tip of the guide catheter. And finally we were able to pull the guide essentially all the way in the body, and the good news are that the fractured balloon did come inside the femoral sheath. That was a nice thing, that we had a long 45 centimeter long sheath, which we typically do for CTOs, provides a bigger target for when things happen like in this particular case. So now the wire came in the sheath, the guide came in the sheath, the balloon fragment, so we're in great shape, and this is what came out. This is the balloon fragment that came out from the H-Friends sheath. In a little close-up, this is the balloon fragment. It was fairly long, and that is why this technique of retrieving the guide catheter worked. And this is the proximal part, the proximal segment of the fractured balloon, showing the area of fracture. It is still unclear about why the fracture happened, but the most likely mechanism was that the balloon shaft was kinked, and then during attempts to advance or retract, that kinking point became weak and finally gave out and fractured. But once again, we had a happy end. We retrieved both fragments of the fractured balloon catheter. After that, we were able to advance another Antegrade catheter. We performed stenting of the Ostial lesion, and then deployed another 3.5 by 12 mm stent and got a nice final result with restoration of TME3 flow, and no injury of the left system on injection on the left side. There was some aortic subintimal hematoma, likely due to the retrograde crossing attempts, but that was stable, and we do know that those do well unless one keeps on injecting contrast and enlarging those. It was a long case and required 4.2 gray and 111 minutes of fluoroscopy time, part of it due to technical difficulty of crossing, but in part due to the balloon shaft fracture requiring maneuvers from retrieval. So in summary, when we have ostial RCA CTOs, the retrograde crossing may be needed. When we're unable to cross within the true lumen, inside the previous lumen and stent, going around the stent and crossing the previous stent is an option that was successfully done in this particular case. The threaded catheter can be very useful for balloon uncrossable lesions, and then torquing and potentially kinking the equipment can cause fracture that requires then retrieval of the fractured balloon catheter. In this particular case, this was achieved by just removing the guide catheter, and because the length of the balloon fragment was long, the balloon came with it and we didn't have any difficulty. It was a unique situation because the fractured balloon was over an externalized guide wire. If the balloon fracture had occurred in a standard angioplasty without externalization, it would have been very easy to just put a balloon inside the guide, trap the balloon fragment, and remove everything out without causing any problems. Thank you very much.